morning, everyone. Welcome to the joint session. This is an effort between the American Society of Nuclear Cardiology, the Brazilian Nuclear Cardiology Group within the Sociedade Brasileira de Cardiologia, the Associação Argentina de Cardiologia Nuclear, Dr. GUSTAVO, representing Department of Exercise Testing and Nuclear Cardiology, Dr. RAFAEL LOPES. So we welcome you, everybody, to this session. We'll have a whole day of imaging pretty much in this room. So I hope you enjoy. There'll be many interactions, clinical cases, and I really hope you have a very, very nice experience. So Rob.
Thanks very much, JOÁO, and thanks to the JOÁO and Rodrigo, the organizing committee, for inviting us. It's certainly an honor for ASNC to be here and to be co-supporting this exciting session and the symposium in general. I'm here with, I'm the current president of ASNC, and my past president, PREM SOMAN, our past president, is also here with us, and he'll speak in a couple minutes. In addition to thanking JOÁO, I want to thank the two medical students who've guided us around, Elizabeth Mioto and Danielle Goss, who are aspiring young cardiologists and pediatric cardiologists. So maybe one day, in fact, I know one day we'll be seeing them up here as leaders in the field. So ASNC is now in 62 countries around the world. It is truly an international society. Of our international members, the majority, or the lion's share, is actually from Latin America, 35%. So thank you to Latin America, Brazil, Argentina, and all the Latin American countries for your support. I'll tell you also, these are the different organizations. Obviously, the Sociedade Permanente de Cardiologia, and the IAEA.
Your Portuguese is getting better by the minute.
By the minute, yes. Obrigado. Obrigado. And a special collaboration with the IAEA and Diana Piazza, who has been a great supporter with ASNC for nuclear cardiology around the world. I want to call people's attention to the journal, whose impact factor has risen above 4. Really outstanding work being done, and continue to invite strong work from Brazil, Argentina, and throughout Latin America to be submitted to the journal. I'd encourage people to join ASNC. The international membership is only $75 and includes complimentary subscription to the journal, special membership rates for online board course, board exam, and prep course, and other online live educational programs, free and discounted webinars, and discounted rate for the ASNC meeting coming up in Chicago. Regarding the ASNC meeting, if you're interested, you can use the code ICMB and pay an ASNC member price for $350, a reduced rate, and follow these instructions. If you have any questions, you can ask me later. If you cannot attend ASNC, you can also sign on and watch it live streaming for 13 of the sessions. This is sponsored by the International Atomic Energy Agency with ASNC, and so again, thanks to Diana Piaz for her support and the support of the IAEA for this initiative. You can connect with ASNC on Twitter, Facebook, LinkedIn, YouTube, and Instagram at these following sites. Thank you very much, and enjoy the day. I hope it's as productive as I anticipate it will be. It's a great collaboration with ASNC and the Latin American societies.
Thank you so much, Rob. Prem?
JOÁO and the other members of the panel this morning, I will only add a few words to what Dr. BEANLANDS has already said. I too bring you greetings from the American Society of Nuclear Cardiology and all your friends in the United States. JOÁO has had a very long and a very special relationship with the American Society of Nuclear Cardiology. And he, and this organization, and all of you, have a very special place in our hearts. So today I thank you for this long association, your friendship, and particularly for your tremendous hospitality, which has made our visit here a great pleasure. So hope you all have a good meeting. Thank you.
Thank you, Prem. Gustavo?
Bom dia. Representação da Associação Argentina de Cardiologia Nuclear, eu gostaria de agradecer à Sociedade Paranaense de Cardiologia pelo convite para realizar o nosso simpósio anual no marco deste congresso. É uma honra para a nossa sociedade integrar este meeting conjuntamente com a American Society of Nuclear Cardiology e o grupo de estudos cardionucleares da Sociedade Brasileira de Cardiologia. Gostaria de destacar o grande trabalho do nosso querido amigo Dr. JOÁO e de todo o comitê da organização até chegar a encontro, onde a gente vai compartilhar experiências e conceitos com profissionais comprometidos na redução da mortalidade cardiovascular. At this time, when the fusion images are so important for the diagnosis, we must have a fusion effort to reach the common goal. All our ships must sail in the same direction. In this way, we appreciate the great support of Diana Perez from the International Atomic Energy Agency. Our association now is ready to work in this task force. Finally, it's a pleasure to meet our dear friends from USA and Brazil. Thank you. Muito obrigado. Muchas gracias.
Rafael, please.
Good morning, and I would like to welcome you all to this amazing meeting. Congratulations to JOÁO, Rodrigo, and all the organizing committee. And thank you to all the faculties that attend us here. Be welcome in Brazil. And I think that we are living in an amazing time for cardiology, in special nuclear cardiology, with amazing challenges also. But I hope that you all enjoyed this meeting. Thank you, everybody.
Thank you, Rafael. So we're right on time, and I'll ask Dr. Leslie Shaw and Dr. Thales de Carvalho to chair the next session. Thank you very much.
Good morning. I think we'll get started so that we can hear the benefit of these outstanding speakers. I think we have Dr. FELIX KENG first from Singapore.
Good morning, everyone, chairpersons, ladies and gentlemen. Of course, I will also bring you greetings from Singapore. If you don't know where that is, it is not in China. It is somewhere in Southeast Asia, and I bring you greetings on this National Day of Singapore. Singapore is 54 years old today. Okay. Okay. No. It's okay. It's too difficult. It's in Malay, so no. Okay, so I'm here to just talk about, actually it's a little debate. I wouldn't call it a debate. It's a debate regarding whether it is better to do CT coronary angiography or nuclear cardiac scans as a first modality for people with suspected coronary artery disease. I have no disclosures. And how do I win a debate? Usually I do character assassination, which of course I will not do here. I will overwhelm my opponent with all the facts and figures, which I have a lot of, or I could pay someone to do something to some other people. So let's start. But why should we debate at all? Why can't we find a win-win situation for everyone? There is something called complementarity of investigations. Why can't we do both? Okay? All tests have different things to offer. Not all tests give the same information or with the same degree of accuracy. So, and of course, not all patients will benefit from all these tests. You really need to be very selective in what kind of tests to do. And there's no one-size-fits-all kind of test for all cardiac investigations. Why do we do myocardial perfusion imaging? Well, it is simple, it is easy to perform, it is accurate. We have a relative or absolute perfusion as a surrogate for ischemia or infarction. We have the LV function and the wall motion. Plenty of diagnostic and prognostic information. This is the strength of nuclear cardiology. And basically, everyone can do it. So lots of people call us unclear cardiology. Are we fighting a losing battle in this field of new wave investigations? What do we lack? Well, we take a while to finish the test. There is radiation. We are not anatomical. Only functional data is available, but I still think that is very important. Getting more expensive as we go along, but every other test is also getting more important. And certainly it is not perfect in detection of ischemia and infarction. So what do we do to try to improve the situation? Now we do, well, myocardial perfusion, myocardial blood flow quantitation. That's pretty good. Our new software and hardware reduce imaging time, reduce the waiting time, and the amount of radiation that is given to the patient. It is improved spatial resolution, which is rather important, and new tracers and stressors make the experience of nuclear imaging much better nowadays. Okay, so we do this. I do this quite often nowadays. It takes a while to do it, but I can quantitate myocardial blood flow with SPECT imaging and not just with PET. And there's lots of guidelines, and if you look at these guidelines by ACCAHA or the ASNIC, there are a lot of appropriate indications in people with symptomatic chest pains, acute chest pains even, and also in other situations. And these are all very well supported by a lot of literature. So the prognostic and diagnostic information here is well known, and it is without doubt very good. So now we ask our question, is anatomy or physiology important? Both are important. Any ideas which one is more important? Hard to say, but of course when I'm vouching for nuclear imaging, I think physiology is still very important. Just two things, two trials that have come about. We look at the PROMISE trial first, New England Journal of Medicine, 2015. Basically, the conclusions were that in symptomatic patients with suspected coronary disease who underwent a non-invasive imaging, the strategy of initial CT coronary angiography as compared to functional imaging using nuclear imaging or stress echo did not improve the clinical outcome of these patients over a median period of 2 years. So not much improvement in diagnostic accuracy in this group of patients up to 2 years. However, when you look at the Scott Hart trial in Lancet in the same year, 2015, does CTA add value to this group of patients with suspected coronary disease? Yes, in the end, okay, there was, well, increase in confidence of diagnosis of coronary disease. However, there were no significant changes or differences in reduction of fatal or non-fatal infarctions. Okay? So in patients with suspected coronary disease, CT coronary angiography clarifies the diagnosis, enables targeted interventions, and might reduce future risks. But this reduction in future risk was not significant as compared to functional testing, but I would caution that all these functional testings were mainly treadmill exercise testing, so not the best kind of functional testing that there was. So that's the data that's available. There's the comparison. I will not take too much time here, but also to mention that we should do all these tests very appropriately. Don't want to do them in patients who will not benefit from these tests, and therefore we should follow the appropriateness guidelines or criteria to best benefit these patients. Right? We've done our own studies, and we are okay in Singapore. Doing nuclear imaging is quite comparable to the data in Americas and Europe. And if we do things right, I think that we have a lot of, a lot of way to go. We can improve this kind of imaging uptake. We do a lot of imaging in our imaging center, and we do about 10,000 patients, myocardial perfusion imaging per year, and this is in one center. As compared to CT, we get about maybe 2,000 CTAs per year, as compared to 10,000 myocardial perfusion imaging. So, oops. Okay. So what should the perfect test be? It basically means that there should be meaningful outcomes based on these test results. There should be symptomatic relief and obviously prognostic benefits based on the results of these tests. There should be less or no side effects. It should be cost-effective and pleasant. Meaningful outcome meaning you don't kill the patients, you make them live a bit longer. Meaningful outcomes in terms of death, myocardial infarction, strokes, revascularization, and its attendant risks, readmissions, and heart failure in the end. So in conclusion, I have plenty of time, both modalities are useful. You must recognize patients' expectations, the pretest probabilities, realize the benefits and risks of all these tests that you would like to do, carefully explain the risks and benefits of the test to the patients. Sometimes the patients help us decide what kind of test they want to do. So that helps, and it reduces all these complaints that you get after you do the tests. And in an ideal world, of course, we would like to do every single test there is for every single patient, but in the real world, that doesn't make it very cost-effective. In conclusion, personally, I usually offer a calcium score with myocardial perfusion imaging in this group of suspected coronary disease patients. And to get basically the best of both worlds, I get anatomy and also physiology. Each test has its own strengths and weaknesses and influence management in different ways. And I would, of course, invite everyone to come and work in Singapore because we have the second worst work-life balance in the world. And this has just come out, I think, yesterday. We are number 2 after Japan, a few US states as well. So, yeah, we work pretty hard and we have no life. Thank you very much.
Thank you, Dr. Keng. The next presentation, Dr. Márcio Sommer Bittencourt from São Paulo, please. Ah, okay.
Bom dia a todos. Good morning. É um prazer estar aqui. Eu vou dar aula em inglês a pedido da comissão organizadora, mas eu só vou me apresentar rapidamente em português. Para quem não me conhece, eu nasci aqui em Curitiba, fiz faculdade aqui na Federal do Paraná. Estou em São Paulo há bastante tempo, tive um tempo fora. E me pediram para falar quase uma continuação da primeira aula sobre métodos funcionais e tomografia. So, let's go. The topic I was asked is whether functional or anatomical method is the best test for initial investigation of chest pain, and I'll take that as stable chest pain. So I'm talking about your outpatient clinic, your stable patient, not your acute ER patient. And I'll take a little bit of a different approach from what Felix did. I fully agree with him that every test has its patient, every patient has its test, but I'll take a broad approach on what happens with most patients and what we can do for most patients to choose the best test, at least for most opportunities, as initial tests. There's others that work for second test, third test, and specific scenarios, but in general, for first test, what do we do? Those are my disclosures. And What I think is it doesn't matter which test you're talking about. The thing is, why do we do any test? A lot of patients don't need any test. And if we want to do any test, we want to answer at least one of those questions, sometimes more than one. We want to know what the patient has, diagnosis. We want to know what's going to happen with the patient, prognosis. And we want to know what can we do with the patient, so define treatment. We don't do testing just because the imaging is beautiful, even when the imaging is beautiful. That's not the indication. So what I'll do is mostly for CT, talk a little bit about diagnostic characteristics of the method, prognostic value, how can we manage based on CT, and then follow with a bit of comparison versus functional tests and see whether one outperforms the other, at least as a broad perspective. So the first thing I want to talk about diagnosis. This data is not new. This is 2008 data from Core 64. For those not used to ROC curves, the idea is the closer you are to this corner, the more accurate you are in discriminating. And what you're looking for here is cath, QCA, so how good you are to see what is in cath based on CT. This is an area of 0.88, if I'm not mistaken, which is pretty good. And that's what's been presented by CT on how good CT is to detect obstruction. Not the data I like the most. The one people don't show that I like the most is the second part of the same study. This is a New England paper. About a quarter of those patients are from Brazil, so it really represents our reality here. And this curve here is to predict revascularization. So how likely the patient is to be revascularized on that lesion compared CT to QCA by cath. So CT is as good or as bad as cath to predict revascularization. Not saying it's great, but it is as good as the standard anatomical imaging we use in the cath lab to define who will be revascularized. So at least diagnostic performance is comparable to other things we've been using for anatomical purposes. The second thing is prognosis. This is data from the work I did at the Brigham when I was in Boston. And prognostic data on CT has usually been, there's no plaque, which is the green here. There is plaque, but it's not obstructive, the yellow and orange here, or there is obstruction, the red and black here. And we usually say, yeah, when there's obstruction, it's worst. But what's interesting is that that's not the only information CT will give you. The presence of plaque, any plaque, even when non-obstructive, has prognostic value. And what we've shown here, this is adjusted for age, sex, symptoms, and risk factors. And what you can see is that when there's a lot of plaque, SIS means just more plaque, number of segments. When there's a lot of plaque, non-obstructive, it is as bad in terms of prognosis as when there is obstruction. So when we see plaque, that means risk, and it should be treated. It doesn't mean that we have to cath or we have to do revascularizations, but it needs management that we can decide as clinicians. How? Basically, you can decide about aspirin, for example. And this is also data from the same data set where we showed before the CTA and after the CTA what the clinicians did based on what they saw. When we saw plaque non-obstructive or obstructive, there was a substantial increase in the use of aspirin. Which you say, yeah, just give medication to everybody. But that's not the whole message. This is part of the data from Walter Reed in Washington, and what they showed is the other side. When there's no disease, there's also a lot of patients where you end up stopping medications. So it's just better tailored. There's patients that need more aggressive treatment, and when you see a lot of plaque and stenosis, you're more aggressive on that side. There's patients that don't need it because they don't have plaque, and you stop the medication. It is not just for aspirin. We have the same data for statins. This is also our data from Boston. And what you see, when there's no CAD, what the clinicians did, basically no change in medications. When there was non-obstructive disease, overall proportion of patients on statins increased. And even with the ones on statins, there's a substantial increase in dosage. You're more aggressive. And when there's obstruction, even more people being treated and more aggressively. But the key question is not whether we increase medication. The question is whether does that change prognosis. And this is retrospective data. We did propensity matching. It's not perfect, but this is all patients with non-obstructive disease. So they were not revascularized. And this is the effect of statins. When there's very few plaque, statin, no difference. When there is substantial non-obstructive plaque, more than 4 segments in our data, the use of statins was associated with a significant improvement in prognosis of symptomatic, stable chest patients that come to the outpatient clinic. You do the CTA, you see some plaque, substantial plaque, but not obstructive. You change medication, you change aspirin, you change statins, and you change prognosis, which is what matters. Prognosis here is just cardiovascular death or MI, so really hard events. There's no revascularizations here. And even to guide the use of revascularization, CT can help you. This is data that Dr. Leslie Shaw was involved from the CONFIRM study, also propensity match, so retrospective data, trying to get the groups as similar as possible. When there's like one vessel, not extensive obstructive disease, it is about the same treating them with medication or revascularizations. When you have more segments or more vessels with involvement of obstructive disease, you're more likely to have more events with medical management versus revascularizations. So the CT anatomical data can help you guide the use of aspirin, the use of statins. There are even some data for blood pressure medication, and can help you guide the use of revascularization. But the question is, how does that perform compared to what we're used to doing? That is nuclear functional testing. And I'll start with the blue bars here. That is a meta-analysis that I did with other people, including PROMISE that was shown before, including Scott Hart that was shown before, and combining all studies, starting with CT versus starting with functional testing, results in 31% reduction in myocardial infarction events. There was an increase in revascularizations, which we're not sure that it's appropriate or not, whether that drives the events, but there was an increase in revascularization. But this is randomized data. This is not real life. The red bars are real life from Denmark. They got the entire country data. They have access to the entire country data. And what they've shown in their data set, compared patients that went to nuclear or functional testing versus CTA, is basically the same. 30% reduction in MI, increase in revascularizations, but also increase in the use of statin and aspirin. So collectively, randomized or real-life data, if you decide to investigate stable chest pains, patients that come to you with anatomical data, you will have more use of medication, probably a potential increase, this is not necessarily true, I'll show you later, but potential increase in revascularizations and a reduction in a very important event that is myocardial infarction. In one of the studies at Scott Hart, they have a little bit more detail on the data, like I've shown before, and they show that the CT, this group, versus the stress testing arm, it's not just that you treat more patients, you also stop more medications when you see normal results. So what you see is that some patients get more medication based on the CT, some patients stop medications based on CT, and this is anti-anginal therapy, so nitrates, beta blockers, and calcium channel blockers. Same thing is seen for preventative medicine. Some patients you stop statin and aspirin, some patients you increase statin and aspirin. So it's tailoring medication based on anatomy. And collectively, what's interesting is that it's not a few patients. You end up changing the prescription compared to stress testing in about a quarter of the patients. 23% of the patients got changes in their prescription based on the CT findings. Same is seen for tests. You can see here CTA versus no CTA. There is a substantial cancellation of additional tests you were planning to do, although there's some increase. So basically, you're separating a good chunk of people that don't need anything, medications or tests, and a group of people that are more extensive disease and need more testing. So the idea is that CT is helping you tailor the treatment based on anatomy. And what's the impact of this? This is 5-year data. That one that I showed from meta-analysis is a 2-year data. After 5 years, the event rate of CTA is almost half of the event of the people that just did exercise testing. And Scott Hart is just regular ETT. There's no nuclear or stress echo or stress MR here. But in the global data, you have a substantial, significant reduction in the event rate of heart outcomes based on the additional use of anatomical data compared to functional data. And the revascularization is the interesting part. This is Scott Hart 5-year data on revascularizations. And the curves are about the same at 5 years. If you look really in detail, it seems that there's more revascularizations a little earlier on CT, and then stress testing start to pick up a little later. So you end up revascularizing patients a little earlier with CT than you do with functional or stress testing. But in general, after 5 years, the revasc is about the same. So probably most of the difference is early revasc plus changes in medication that impact Scott Hart data. And the other question I usually get is whether that idea is cost-effective. I hear people saying, yes, CT is too expensive for us to do it, and it depends on the reality, it depends on how much you charge for a nuclear or for a CT. But this is data from a group in Netherlands, and this is data, they did it for Netherlands and then US reality, at least for their costs. What they did is a cost-effectiveness analysis. So this is modeling data. All tests followed by invasive testing, that's the eye, or start with CTA, then do functional, and in some of them, after functional, you do invasive testing. Up here is cost, down here is quality, or just quality of life. So the more you are to this corner, the lower left corner for me, right corner for you, the less expensive and more life you're buying. So this is poor bang for your buck. You're too expensive or not worth it. And the more you are around here, the better. And all the crosses that are here are start with CT, then do some functional, whichever functional it is, then CTA. Probably there's some data that suggests that echo might be a little minimally better for this cost, but in general, the idea is CT first, nuclear or stress echo or MR later, and then cath. The more selective you are, starting with anatomical data, the better you will perform. And just to finish, the UK guidelines already are following that recommendation, and they say every patient that comes with stable chest pain, typical or atypical symptoms, should go CT first. So I'll conclude by saying that CTA is useful for prognostic evaluation, including data for non-obstructive disease. It's useful to tailor medication, particularly aspirin and statins, but also procedures. And it is better than functional testing for the initial evaluation of chest pain. And it may or may not increase revascularizations depending on how you practice and how far along you look at it. Okay, thank you very much.
Thank you, Marcio. I think we'll move on to Dr. Luis Eduardo Mastrocola, who's going to speak about exercise testing. When is it enough?
Bom dia a todos. Eu vou estar falando em português. I know that I have a hard task this morning, Dr. Leslie, because defender o teste ergométrico quando tanta tecnologia está disponível. Quando nós falamos de teste ergométrico, na nossa realidade, no Brasil, será que nós temos espaço ainda? Ainda. Vocês veem naturalmente que nós estamos num congresso clínico de multimodalidades, onde o teste está colocado muito bem nas suas indicações pelas diretrizes. E se eu olhar o teste ergométrico hoje, estão lá colocadas para vocês as duas possibilidades onde o teste é apropriado, ou na baixa probabilidade intermediária com eletro interpretável, ou então na probabilidade intermediária. Aí eu coloco o teste, e a nossa realidade do Brasil é esta, efetivamente, ante tantas as modalidades que aparecem hoje. Sem dúvida nenhuma, eu estou de modo indissolúvel com o binômio diagnóstico-prognóstico. Eu não falo de diagnóstico sem falar de prognóstico. Mas eu tenho que conviver com a mudança do paradigma agora, que é a detecção subclínica da aterosclerose através da detecção do cálcio. E seguramente o que todo mundo quer é melhora de evolução, é dizer para o meu paciente, se aquele teste é normal, qual é a chance dele morrer em 1 ano. Ele tem menos que 1%, ele está entre 1 e 3, ele está acima de 3. Então, evolução é o ponto aqui. Quando nós olhamos, é claro que eu dependo da população que eu estou olhando. Esse é um grande estudo longitudinal de assintomáticos. Eu olho que mesmo que o teste não seja recomendado como classe 1, ele ao longo do tempo mostra valor preditivo para eventos, especialmente se eu tenho ou não fatores de risco. Estou colocando primeiramente e novamente a probabilidade pré-teste de doença. Vejam que quando eu tenho um teste ergométrico positivo sem fatores de risco, olhem o risco relativo que ele tem para desenvolver eventos. Quando ele tem 3 fatores de risco, olha para onde vai esse risco relativo. Essa informação é importante olhando o teste no assintomático. De qualquer maneira, parece ser uma ferramenta válida também em pacientes apropriados, em termos de predizer risco de morte. É claro que aqui o teste, e a doutora Leslie, na verdade, é responsável talvez por este paper, o teste é suficiente, por exemplo, para algumas populações de mulheres. Vejam este estudo, onde 800 mulheres foram randomizadas a teste ergométrico e a cintilografia, mulheres hábeis a exercitar-se pelo questionário de atividades, e após 2 anos de seguimento, a evolução foi a mesma. Então, nós poderíamos dizer que nas mulheres apropriadas, risco intermediário, que tem eletro de base normal, o teste seria suficiente. Neste primeiro momento, defender o teste na nossa realidade ainda é muito importante. Então, uma primeira colocação, e nós sempre falamos, vamos simplificar as diretrizes, nós andamos um pouquinho nos anos, e existem propostas, então, olhando o grupo de mulheres, se eu tenho, então, uma mulher de baixo risco ou de risco intermediário, eu posso apenas perguntar se ela se exercita, eletro de base normal, e eu posso falar, ou eu não vou fazer teste nenhum se ela for baixa, ou eu vou fazer um teste ergométrico, ou adicionar talvez a ferramenta mais custo-efetiva hoje, que seria um teste com detecção de cálcio nas coronárias. De qualquer maneira, pelo fato dos algoritmos clínicos hiperestimarem doença, num momento isso foi dito, foi definido, os algoritmos normais como Framingham, Procan, Score, Reynolds. Então, criaram-se novos marcadores, novas diretrizes aparecem, criaram-se novos marcadores aonde, por exemplo, a capacidade funcional e a detecção de cálcio nas coronárias guarda papel vital para essa definição. Muito bem, a partir agora de uma atualização dos scores clínicos, do score de Diamond, criaram-se novos scores para prever probabilidade pré-teste de doença, e chega-se ao final, num elegante editorial publicado por Dr. Di Carli, agora no Journal, a dizer que não é momento de nós abandonarmos os algoritmos clínicos para estimar a probabilidade pré-teste, porque isso pesa dentro do raciocínio médico. E, em função disso, quando nós olhamos a performance de vários algoritmos clínicos para a estimativa de probabilidade, nós poderíamos dizer que talvez um dos algoritmos que exibe melhor performance seja o algoritmo dos pacientes que saíram do Scott Hart Trial, os pacientes adicionando, então, além de sintoma, idade e sexo, adicionando fatores de risco e adicionando score de cálcio. De qualquer maneira, o teste ergométrico ele tem poder se eu olho todas as variáveis, desde diagnóstico, prognóstico, considerantes de detecção de isquemia, anormalidades de pressão arterial e frequência cardíaca no exercício, capacidade funcional a arritmias, estabelecendo o prognóstico e auxiliando no processo de decisão clínica nas intervenções a serem decididas. E nós poderíamos listar para vocês, então, todas as variáveis onde o teste de modo multifatorial poderia participar. Nós saímos daqui agora e nós passamos para o que nós chamamos agora de colocar o paciente no centro. Essa é uma publicação brasileira do João, aqui do grupo do João da Quant de Curitiba, onde é o Patient Centered Imaging, eu coloco o paciente no centro e eu faço as perguntas para esse paciente. Isso está colocado na nossa diretriz que será publicada agora. Qual é o perfil clínico, qual informação eu estou procurando, qual teste e que teste me dará a informação e se eu preciso alguma outra informação para manejar este paciente. E aí propõe-se pelo próprio autor aqui, pelo próprio João, um passo a passo para avaliar meu paciente e talvez estimando probabilidade pré-teste, eu decido se eu faço o teste ergométrico, se eu adiciono o teste ergométrico ao score de cálcio, e isto serve um filtro para eu prosseguir na minha investigação para a tecnologia mais moderna, para a tecnologia que agrega valor prognóstico incremental, para depois a decisão sobre a manutenção do tratamento clínico ou a intervenção. Então, esta é uma proposta e nós temos esta proposta absolutamente dentro do Brasil de modo sedimentado. É claro que se eu falo de capacidade funcional ela prediz mortalidade para qualquer fator de risco que eu tenha. Imaginem aqui num trabalho elegante, se eu alcanço uma carga metabólica satisfatória, eu morro menos, tanto se eu for hipertenso, doença pulmonar, diabetes, fumante e outros fatores de risco. Então, capacidade funcional. Neste pormenor, capacidade funcional, num elegante trabalho de 2009, Dr. James Burke, da Universidade da Virgínia, olhando aqueles indivíduos que atingiam capacidade funcional adequada, acima de 10 metros de carga metabólica, e aqueles que atingiam menos do que 10 metros, quando se olhou a prevalência de isquemia de área extensa, naqueles com capacidade funcional pequena, a isquemia maior que 10% incidia muito mais do que naqueles que tinham capacidade funcional elevada. Vejam que naqueles indivíduos que atingiam mais do que 10 metros de carga metabólica no exercício, a frequência de isquemia foi praticamente zero. Isso se confirma alguns anos depois, com um estudo prognóstico, olhando também que esses indivíduos com alta capacidade funcional, também eles têm uma evolução bastante satisfatória. Poderíamos dizer, então, que com a simples medida da capacidade funcional, pode ser um fator decisor no meu processo de decisão clínica. E eu passo para os scores. O score de Duke, validado entre nós, vocês conhecem, então validado a partir de 2.800 pacientes admitidos no hospital com teste e cinecoronariografia, depois validado ambulatorialmente, e dentro do score de Duke, que pega as variáveis do exercício, tempo, desvios de ST e um índice de angina, criam-se então grupos de alto risco a partir do resultado do score. Se esse score é menor que -11, se esse score é maior do que +5, vejam esses dois extremos. Quem tem esse resultado do score, olhem a sobrevida livre de eventos aqui, e olhem quem tem esse resultado do score, olhem a sobrevida livre de eventos. E aqui cabe colocar um trabalho também brasileiro de importância, que é o trabalho aqui também do Quanta de Curitiba. Vejam, de 17.900 pacientes do registro aqui da clínica de Curitiba, do Quanta, do VITOLA e colaboradores, descobriu-se 340 indivíduos com Duke score de alto risco. Desses, o que eu poderia dizer então? O teste ergométrico é suficiente para tomada de decisão se eu tiver score de Duke de alto risco? Eu estou com o teste isolado, aqui são pacientes encaminhados para cintilo, mas 30% aproximadamente desses pacientes tiveram cintilografia anormal, normal, e 70% cintilografia anormal. Então, eu estou dizendo aqui que o score de Duke errou em 30%, porque em 30% eu tive cintilografia normal, com score de Duke de alto risco, e aí entra então a probabilidade, que perfil do meu paciente que eu estou estudando para eu tomar a decisão. E olhem que quando a cintilografia é anormal, ou quando a cintilografia é normal, a taxa de eventos é significativamente diferente. Torna-se importante colocar, então, eu tenho uma ferramenta hoje de valor prognóstico incremental evidente, que vale para populações como mulheres, como idosos, não tão bem definida, mas que eu posso efetivamente aplicar na prática clínica. É uma ferramenta efetivamente de grande valor. Aqui um cenário para vocês, mais 2 minutos nós terminamos, para vocês entenderem. Um paciente que é 55 anos de idade, com uma dor atípica, 2 semanas antes dele realizar esse exame, ele liga ao médico, o médico solicita então uma cintilo com teste. Vejam o padrão que ele faz no teste então, um teste de alto risco com supradesnível de segmento ST. Quem não diria então, quando eu calculo neste paciente que simula um eletro de síndrome coronária aguda, quem não diria então que, olhando o score de Duke, um score de altíssimo risco, eu já não poderia tomar a decisão e encaminhar esse paciente, então, para CAT diretamente. Como ele havia feito a própria cintilografia, a cintilo mostrando uma área extensa de isquemia e também já uma área de perda, talvez ele tivesse tido já há 2 semanas uma dor que não foi tão bem definida. Esse paciente com marcadores de alto risco na cintilo vai a cine e é um paciente, então, triarterial. E para nós finalizarmos, então, poderíamos olhar vários cenários cenários. Aqui é uma apresentação do score de Duke numa população idosa do Dante Pazzanese, onde aqueles que têm score de Duke de alto risco, 50% têm isquemia, e entre risco intermediário, 25%. E quando nós olhamos o último cenário, poderíamos escolher muitos cenários para mostrar para vocês, para perguntar também, o teste ergométrico foi suficiente ou eu teria que adicionar um método específico que pudesse me agregar valor? Aqui uma senhora de 50 anos que referia a arritmia por vezes, já estudada 1 ano atrás, na data que ela foi encaminhada, com uma medicina normal. E ela vem então para repetir um teste ergométrico por uma queixa frustra de arritmia. A lembrar que a MIB, naquela ocasião, frequência cardíaca foi abaixo da esperada, ela usava beta-bloqueador, um eletro de base com alterações aí inespecíficas da repolarização. Ela faz um eletro com alterações também um pouco maiores, mais inespecíficas, mas ela atinge uma boa capacidade funcional. Poderia parar aqui este exame? Eu tenho um teste anterior, eu tenho uma cintila anterior normal, eu poderia parar aqui a minha investigação. Essa senhora continuou naturalmente, ela tinha uma cintila normal, totalmente normal, e ela acaba também no final fazendo uma angiotomo, e a angiotomo é completamente normal, com score de cálcio 0. Aqui apenas para mostrar que teoricamente eu poderia ter parado. E para finalizar então, para vocês, tivesse que propor um algoritmo simples para vocês, a simples pergunta de perguntar, é um candidato a teste ergométrico? Tem boa capacidade funcional dentro do valor predito? Sim ou não? E aí então eu seguiria uma sequência. Eu posso fazer um teste ou um teste com score de cálcio, se não for sintomática, e eu defino o meu risco e manejo este meu risco. Se for um risco intermediário ou alto, eu posso partir então para a metodologia associada, e a depender do paciente eu posso auxiliar minha tomada de decisão clínica. Muito obrigado.
Thank you, Dr. Mastrocola. Next presentation, Dr. Stephen Towers from New Zealand, coronary artery calcium score. Wayne is only this test enough.
Bom dia. So I'm from New Zealand and originally a United States citizen, and would like to thank JOÄO for kind invitation. It's a great honor to speak to such an august group of people in Curitiba, or as Nathan Better, my colleague from Australia, would say, Kurajima. Well, I'm going to try to make this as practical as possible. I'm a clinician. I see patients every day. And what I like to do is have you look at this CAT scan. And there's an emphasis on anatomic imaging, functional imaging, but we do both at Palmerston North, New Zealand. We look at the attenuation correction scan and score calcium visually, which we find very helpful, as well as the functional imaging. And when we're on rounds in the hospital, we often look at a patient who's had an old CAT scan, who comes in with atypical chest pain, and we say, what does the coronary tree look like? So all of the medical students out there, this is the coronary artery, and this low-dose attenuation correction CT, showing the left main, circumflex, and the LAD. So does anyone have any question about the degree of atherosclerosis in this patient? Is it low? How many people think it's low? How many people think it's high? So visual interpretation of a chest CT can be very helpful. And the lack of calcium is what I'm going to talk about, because that's when coronary calcium is enough. Well, this is from the European Society of Cardiology journal. It was just this week showing the various modalities using CAT scan for patients with suspected stable angina pectoris. Coronary calcium looks at atherosclerotic plaque burden, Well, the injection of contrast allows you to look at stenosis. There's a stenosis in this patient with moderate coronary calcification, the LAD. And interestingly, there's some new work. Is anyone doing CT PET fluorodeoxyglucose plaque vulnerability? Yes. Ottawa, Canada is at the lead here. Anyone else going to raise their hand? No? One institution. And so these studies are available, but what I'd like to do today is talk about atherosclerotic plaque burden or the lack of it. Well, why would you want to do a coronary calcium score? As I said before, you don't need to do a CT-gated Agassiz score. You can, with a hybrid system, you can visually assess the coronary calcium. It's a quick scan, takes 5 to 10 seconds. Every hospital in the world has a CAT scanner, just about. So it's widely available. And it's very low cost. You don't need contrast. Slow radiation exposure, less than a millisievert. And the thing I like to emphasize today is the large evidence to support prognostic implications of a coronary calcium score of 0. So why is that? Well, what we can see here is a representation of the development of coronary atherosclerosis. And as the plaque develops, it calcifies. And the more calcification, the higher the plaque burden. That's been well established. So someone with a very high calcium score has a very high plaque burden, and someone with no calcium in an appropriate age group has no plaque burden. So what we do in our institution, we use low-dose gated CT of the chest, and when we see a calcium score of 0, we equate that with the absence of atherosclerotic plaque. And you can see here, comparing this left main LAD circ to the one previously, does anyone see a difference? No one sees a difference? There's no calcium here. The other patient had severe calcification. This patient has no calcification. So as a clinician, using CT, either gated, non-gated, visual, or Agassiz score, you can risk stratify patients and use a low-dose gated CT with a calcium score of 0 as a filter or gatekeeper for further testing. So we call this the power of 0. The prognostic power of 0 is what I'm going to try to convince you of tonight. Well, this study, looking at the prognostic value of a CT angiogram versus a CT coronary calcium score in low-risk patients who were referred for suspected coronary artery disease from Korea, and over 4,000 patients, shows that a coronary calcium score of 0, the yellow line here at the top, had the same prognostic value as a coronary CTA, which was normal. There was event-free survival in 99% of the calcium score of 0 patients, which was the same as you had a normal coronary angiogram. And if you notice in this study from Korea, over half the studies had a coronary calcium score of 0. So you could say, if you'd like, that perhaps they could screen these patients a little better, because if there's no prognostic benefit of doing a CTA, a coronary calcium score of 0, then why are we doing it? This is a study my colleague Dr. Better showed yesterday, showing the independent prognostic value of a calcium score using CT and myocardial perfusion imaging. And what it shows here in the bottom that if you have a coronary calcium score of 0, it doesn't matter if your perfusion scan is positive or negative. The powerful prognostic value of a calcium score of 0 overweighs any small perfusion abnormality that may be due to attenuation artifact. And these patients have less than 1% one-year cardiovascular event rate. So again, why do a functional image if the functional image doesn't impart any important prognostic information? Powerful prognostic information with a calcium score of 0. And this is a study from my friend John Mamarian, Houston, looking at patients who present to the emergency department with chest pain suspected of coronary disease without diagnostic ECG or normal troponin. And what it shows is that the event rate in patients with a calcium score of 0 is very low, less than 1%, 0.3%. And it's more predictive than a normal perfusion scan, the risk stratifying patients who present to the emergency department with a calcium score of 0 have a very, very good prognosis. So let's go now to the NICE guidelines. Is everyone familiar with the NICE guidelines? In 2010, the NICE guidelines quoted this paper from San Francisco. In 2,000 symptomatic patients who had a coronary calcium score of 0 found that it was highly accurate ruling out obstructive coronary disease. An appropriate age group, age greater than 50. That's the Achilles heel of calcium scoring. If you do it too early, you're going to miss some non-calcified plaque. But in these patients, sensitivity was 99%. And on this basis, in 2010, from this publication in Heart, the NICE guidelines endorsed the use of coronary calcium testing for stable symptomatic patients. It's used as a filter in a binary fashion. Calcium absent, filter out of further testing. Calcium present, go on to further functional testing. Now, the NICE guidelines no longer says that, but I think that their initial evaluation and recommendation was accurate, that coronary calcium score of 0 can be used as a filter or a screening tool. And again, looking at this study in Open Heart from this year, on coronary calcium score in patients with CTA stratified with a calcium score of 0, majority of these patients, 98%, had normal coronary arteries or non-obstructive coronary atherosclerosis. And the fact that there were some patients with non-calcified plaque did not impact the prognosis. The major adverse cardiac event rate was less than 0.19% at 2 years. And then this study from London in the European Journal of Cardiology showed that a 0 calcium score had a predicted value of 99.5% with an annual event rate of 0.3%. And they felt that it could be used as a screening tool or a gatekeeper, obviating the need for more expensive tests. So the power of 0. So I'd like to turn now to Leslie Shaw and congratulate her for this study she did looking at 10-year resource utilization and the cost of cardiovascular care in patients with coronary calcium score of 0. As you can see on the left, those patients with coronary calcium score of 0 had a very low cost utilization or resource utilization at 10 years, less than $9,000, opposed to those patients on the right, where a calcium score was greater than 400, cost utilization was much higher, almost $40,000. So identifying patients with calcium score of 0 identifies a low-risk patient, has an excellent prognosis, is going to have low resource utilization, and we don't need to do a lot of expensive testing. Power of 0. So this young lady here has her arms raised in the air, running through the fields of golden wheat with sun shining on her. And the reason is she has the power of 0. Thank you.
On that note, we'll have our last speaker of this session come up, Dr. Andrew Einstein from New York. Is going to be talking about future perspectives on imaging-guided treatment. Andrew.
Okay. Thank you, Dr. Shaw. Thank you, the other chairs, Dr. Vitola, Dr. Cersei. It's really a pleasure to join all of you here in Curitiba. So I'm going to talk about future perspectives for imaging-guided treatment. I'm just looking for, is there an advancing? Let's see. There we go. Okay, as we envision the future of cardiology, it's clear to me that the role of imaging in guiding treatment will be truly transformative. Across imaging modalities, new approaches will take imaging to higher levels, allowing improved and personalized guidance of therapy. Moreover, new technologies will play a critical role in visualizing the masses of data we collect to select, plan, and in real life, guide therapies. Unfortunately, we don't have time to discuss all of these exciting developments, but I'd like to briefly discuss with you two game changers in how we use today's cardiac imaging modalities and two future technologies which I'm beginning to incorporate into my own practice. This is a standard myocardial perfusion imaging scan. You can see an anteroseptal perfusion defect here, and this translated in this patient to a tight stenosis in the patient's left anterior descending artery. In fact, the perfusion defect, which represented ischemia, plays a powerful prognostic role. In this classic observational study from Hakamowicz et al., patients with at least 10% ischemia on myocardial perfusion imaging benefited in this observational study from revascularization as compared to medical therapy. We can do similarly in cardiac PET by characterizing myocardial perfusion imaging. Here's a patient with normal or near normal PET myocardial perfusion imaging, but what we found to be abnormal in this patient is a parameter called myocardial blood flow reserve. What we can do in PET is using biokinetic models quantify myocardial blood flow at both stress and rest, take their ratio, and that ratio is called the myocardial blood flow reserve. It plays a powerful and complementary role in prognosis. In this study, you can see that division of patients between tertiles of myocardial blood flow plays an important complementary role to myocardial perfusion imaging. Patients in the upper tertile, that is with a myocardial blood flow reserve of at least 2, have much lower mortality rates than patients in middle and higher tertiles. 6 times higher event rates in the middle tertile, 12 times higher in the lower tertile. This has implications in terms of guiding therapy. In the panel on the left, you can see patients with low CFR, which is the same thing as myocardial blood flow reserve, just another name for it. Patients with low CFR who were not revascularized had much worse outcome. But it depends on what type of revascularization is performed. Specifically, patients with coronary blood flow reserve, which was low, who underwent percutaneous coronary intervention, had similarly high event rates, whereas patients who underwent coronary artery bypass surgery had lower event rates. Here, this powerful prognostic tool also can help us guide therapy. We saw this classic figure where the curves cross at an ischemic burden of about 10%. We now have a similar curve for myocardial blood flow reserve at a cutoff of about 1.8. So patients with myocardial blood flow reserves of less than 1.8 will benefit from early revascularization, at least based on this observational data. You may say, well, I don't have PET here in my laboratory in Brazil. Well, myocardial blood flow reserve is coming soon to SPECT. Many centers are doing this now, and I think this is something which you're going to be able to incorporate into your practice. Let's change gears. Let's look at assessment of blood flow by cardiac MRI. This patient, as you can see, has a jet of aortic regurgitation. How do we quantify how severe that is? The traditional method is to perform phase contrast myocardial resonance imaging. We can look at blood flow into and out of a plane, quantify that, and look at the amount of regurgitant blood flow to quantify that aortic insufficiency. However, that's dependent on selecting the right plane, and many technologists may not do that right, and we may discover things after the fact. The next step is to assess blood flow using four-dimensional techniques. Standard 2D phase contrast MRI lets us look just in a single slice, whereas 4D flow acquires a volume of data over time, providing information on the temporal and spatial evolution of blood flow with full volumetric coverage of any volume of interest, where we can slice and dice it how we'd like, look at any plane. Here you can see an illustration of 4D myocardial blood flow. You can see this jet, which may have looked mild before, looks more severe here, and we can quantify that. We can look in different planes and look at how this regurgitant blood flow is in 3 dimensions. There's a variety of visualization techniques we can use: vector graphs, velocity, maximum intensity projections, streamlines, time-resolved path lines, and these can help us better evaluate blood flow. Here you can see, in fact, these vortices of flow, turbulent flow, and indeed this patient had a regurgitant fraction of 40%, severe aortic insufficiency. We can look at other pathologies with 4D flow as well. Aortic stenosis, where we can look at a variety of parameters, including the wall shear stress, turbulent kinetic energy and pressure, parameters which we just could not assess using traditional techniques. In fact, in patients with bicuspid aortic valve and aortic aneurysm, we can assess wall shear stress using these 4D flow techniques, and we find that this has important pathologic correlations. There's a decreased number of elastin fibers seen in black in this histopathology in the context of elevated wall shear stress. We can assess other pathologies, mitral regurgitation. For some reason, this doesn't seem to, here we go. So we can assess mitral regurgitation as well in 4 dimensions, and we can look at it in a variety of planes. We can assess congenital heart disease. This is not simple pathology. This patient has both aortic regurgitation as well as pulmonary stenosis. We can assess all in a single acquisition of this patient. A net result is that here's one patient who was assessed before and after the availability of 4-dimensional flow. In the old protocol, acquisition took 90 minutes using the new 4D flow, much shorter acquisition time, and better assessment of information. Let's move on to 3D printing. My colleagues and I have been benefited a lot over the past few years of using 3D printing to understand anatomy to improve treatment. Let's talk about one case in particular. This patient was identified prenatally. The patient was found on fetal echocardiography to have demalposition of the great vessels, a remote ventricular septal defect, conal tissue below the aortic valve with possibly causing aortic obstruction and aortic coarctation. However, the exact relationship of the VSD and great vessels was complex, not clearly delineated. There's a number of potential VSD locations, as illustrated in this Brazilian publication, and there were a couple of surgical options which we had for this patient, either a palliative procedure or a primary repair. Each had their pluses and minuses. And we really weren't sure what the anatomy was and whether it would lend itself to primary repair or not. How could we get both ventricles to connect to the outflow tracts? Was the VSD large enough for a conduit for blood from the left ventricle? How could we answer these questions? We performed a CT scan at a very low radiation dose to the patient here. Here's a two-dimensional slice through this CT scan. You can certainly see there's a ventricular septal defect here. However, how can I plan surgery from it? Three-dimensional rendering techniques, simply insufficient here. But what we did is we used 3D printing. 3D printing is a manufacturing method using an additive effect. We can print successive layers one at a time and build complex and custom parts, like this heart you can see here. We segment the structures of interest, we create a 3D surface model, and do 3D printing. In this patient, we in fact printed 3 different models using different types of 3D printing. Both an extracardiac and an intracardiac model where we put different planes in. This demonstrated a straight shot from the ventricular septal defect to the pulmonary artery. It was amenable to tunneling despite a so-called non-committed VSD, which was remote from the aortic and pulmonic valves. It demonstrated a VSD large enough for a suitable conduit with minimal enlargement and delineated the conal tissue for resection. This patient underwent primary repair and is doing great today. The CT anatomy was great for planning the repair and minimizing cross-clamp time. Let's move on to a final technology, augmented reality, also something which we're starting to do. Augmented reality is a combination of a real scene viewed by an individual with a superimposed virtual scene that augments the scene with additional information or subtracts unneeded information. Augmented reality can add previously acquired data or computer-generated data to enhance visual, audio, proprioceptive, or other sensory perception. It's distinguished from virtual reality in that augmented reality includes data from the real world as well, and there are various devices which you can wear and use. Here's me wearing one of our devices. In fact, this is a VR device. The goal is to enhance perception and performance in the real world. Here's one of my students and one of our three-dimensional models which we incorporated into augmented reality. I'll show you how we can manipulate these models and use it to guide therapy.
Train. Hands free. Move. Stop. Rotate. Stop. Scale. Stop. Transparent.
One example in which we've used augmented reality in limited instances is for assisting in cerebral angiography. We have 9 patients who've undergone diagnostic neuroangiography with my neuroradiology colleagues with AR guidance, and 18 controls without. The neuroradiologist visualized on the head-worn display a 3D model of the aortic arch, carotids, and vertebral arteries from CT or MRI images. The model is manipulated using these voice commands which you've seen, gaze and gestures while maintaining sterility. What we've observed in this limited sample is a trend towards reduced fluoroscopy time, reduced radiation, and reduced contrast. I think I'm out of time, so I'm going to stop here. But certainly, there are many technologies which we can use and many advancements to today's modalities in which imaging will truly transform the way we intervene upon patients. Thank you very much.
So we have a few minutes, maybe 10. If the speakers could come up to the podium and we could have some discussion. Questions? Anybody have some questions? While the speakers are coming up, maybe I could ask some of the folks in the audience, how many people, there's a question. Yes. Go ahead, sir. Yes. The microphone is coming to you.
Good morning. I have a question to Dr. Márcio. So I'll ask in Portuguese, okay? Márcio, a nossa última diretriz brasileira de dislipidemia classifica o paciente com score de cálcio de 0, mas com placas na angiotomografia como um paciente de alto risco. Eu gosto muito do score de cálcio como estratégia de estratificação de risco para os meus pacientes na minha prática rotineira, porque é um exame barato e que me dá várias informações. Mas fica sempre aquele receio do paciente ter score de cálcio de 0, mas talvez ser um paciente que tenha placas ateroscleróticas na angiotomo. Como pensar na questão prognóstica desse paciente que tem score de cálcio de 0, mas com placa?
Eu acho que assim, okay, I'll translate the questions for those that didn't get it. I'm not sure everybody got it. It's a simple question of risk stratification and CT versus calcium score, and what to do with calcium score of 0 considering the idea of non-calcified plaques. Also because in our guidelines in Brazil for dyslipidemia, the presence of plaque is considered a high-risk stratifier if you have a CTA. Not that it is indicated, but if you happen to have it, it is considered high risk, even though calcium score might be 0. I think I can answer those things. Sorry? Yeah, I'll just quickly address it now, because I think you might have more to say than me. But I think for asymptomatic patients, there are good data with calcium score of 0 is good prognosis, even if there is a little bit of plaque. So I think that's good enough. And it's very unusual for a patient with calcium score of 0 and being asymptomatic have a huge amount of plaque, and very mild plaque probably won't mean that much for those patients. So I would still stick with the calcium score for the asymptomatic, but I'll give somebody else a chance to give a tweak on that.
So the important thing I think that we need to remember is that these calcium scores of 0 should be in age-appropriate patients, and the guidelines suggest that women greater than age 40, men greater than age 40, and women greater than age 50 will have a high percentage of calcified plaque and a low percentage of non-calcified atherosclerotic plaque. So that's the first thing. The second thing is that the prognostic implications of a non-calcified plaque in a patient in the appropriate age group their prognosis is excellent, with a less than 0.3% annual cardiac event rate in that group. So I think in New Zealand we're resource limited, and doing a lot of expensive tests with contrast is cost prohibitive, and I think we need to look at the best bang for our buck. A calcium score of 0 has a very powerful prognostic implication in the appropriate age group, and I'd just like to emphasize that.
Any other questions? Prem?
So along those lines, you know, the most recent cholesterol guidelines have started to bring calcium score to help us guide treatment. So now I'm talking about treatment, not just diagnosis of patients with chest pain. Do we have any data on what happens to calcium score over a period of time? So if you take somebody like a South Asian who has sort of intermediate risk, and then you say they have a calcium score of 0, so I'm not going to start statins. How long is that warranty period good for? And the second question is, you know, if you have firm indications for statins, let's say you're 45 and you have diabetes, then what happens if you have a calcium score of 0?
I think there's good data. It's all observational. There's no randomized data based on that. But if you look at calcium scores, especially calcium score 0, there's at least a couple of papers looking at how long does it take before the events start to happen. And for virtually any group, it's more than 5 years. So 5 years is a good warranty period. There's a paper by Uma Valenti in JACC Imaging that says, even for all-cause mortality, you're below 1% per year, so like less than 10% in 10 years, even if you're framing high risk, or even if you're diabetic, or even if you're age 65. So as long as the calcium score is 0, the prognosis is good, maybe not for 10 or 15 years, but at least about 5 years. There's also a lot of work that LESLEE has done on that, so she might even have some additional input. But in general, for most of the ones that would be appropriate, that is the range. There's one caveat, I would say, the very high risk in Framingham, if you look at the main paper that led to the guidelines, if your ASCVD risk is above 20%, then probably the event rate in 10 years will be about 10%, and probably then you would still treat. So I'd say below 20% risk, not that great idea that trust the calcium score, just treat because the baseline clinical risk is too high. But the other groups, most of them would have good enough validity for at least 5 years, many groups more than 10 years.
So just to follow up on that, so in an intermediate or high intermediate, or the diabetic patient that Prem described, with a 0 calcium score, you would or you would not treat with statins?
So if it's an intermediate risk, I would say you don't need to treat with a calcium score of 0. I always say it's not like flat written in stone, because it's all a risk-benefit discussion with the patient and whether you want to take medication or not. I think there's both extremes that they never want or always want, but in between, I would be comfortable with the calcium score 0, at least for the intermediate being ASCVD 5 to 20%, to not treat them and reconsider after a couple of years. I mean, this is the discussion for statins. The way I take it is that we're on a point where we can even move forward, and I think we can use in a different way, and I probably won't have time to get into that, but even to talk about other therapies. And I think you can discuss how to use aspirin based on that. There's even more controversy on that. But even other therapies, when is the risk high enough that we should get the diabetics and discuss like SGLT2 inhibitors, because there's enough cardiac disease that we should be more aggressive on other stuff. So I think there's more on plaque burden by calcium score to guide therapy beyond statins, but what's in the guidelines, statins, I would be comfortable with the 0 up to 20% ASCVD risk, my personal take.
Thank you. In the cohort that you study with a patient who has serious cold, how many patients have soft plaque?
So it depends on the study. There are many studies looking at CTA, comparing it to 0 calcium score. But the important thing that I want to stress here is that it needs to be age appropriate. If you're doing calcium scoring in young women, you're going to see a lot of non-calcified plaque. So the incidence of calcified plaque goes up as the patient ages. So the age-appropriate patient, the incidence of non-calcified plaque in a patient with 0 calcium score is around 1% or less. So it's 99% negative predictive value.
And which is your treatment about this 1%? You have to have treatment with statins or something so? aspirin?
Well, if you do a CT coronary calcium score and it's 0, the prognosis in those patients, or the cardiovascular event rate, is around 0.1 to 0.3% per year in multiple studies. So these are extremely low-risk patients. And if you, so no test is perfect, and you're going to miss some patients, but it's got extremely high negative predictive value and a very, very low cardiac event rate.
Thank you.
I know Nathan has a question. Nathan, Dr. Better in the back. Oh, back. Nathan was first. Sorry. Way in the back. Nathan, maybe you should just yell.
Thank you. I have a question for all of the panel, actually, to take my colleague's previous question one step further. We all who practice in CTA have the one patient which is 50 years old with chest pain, calcium score of 0, and a severe soft plaque, which the patient ultimately goes to the cath lab and has a stent put into their LAD. Now, the data which you showed, Stephen, showed quite nicely that this is less than 1%, and the prognosis of the group is very, very good. But my question to the panel is the medico-legal implications in 2019 of missing this 1 in 200 patient, and what are we going to do with them? And when the lawyers come to us and say, well, you missed that plaque because you only did a calcium score.
Andrew, do you want to, let's go down. Maybe we could.
I think the medical legal implications are going to vary a lot depending on what practice environment one's in. I don't know what the medical legal climate is in Brazil. Certainly we have a hypersensitive medical legal climate in the United States. I think in the diagnostic rather than in the prognostic space, in the United States, a calcium score would probably be regarded as insufficient. It's not supported in current guidelines, and it would be very easy to find many expert witnesses saying that it's not an appropriate standard of practice to simply perform a calcium score in a symptomatic patient. In an asymptomatic patient, I think such issues don't arise. Does that address your question?
Felix, do you want to? No? Anybody else want to comment on it?
I was about to say that perhaps if you do one test and it doesn't solve the question, keep on doing tests. The more tests you do, the less risk of missing things.
I think, as Andrew said, it depends on where you are. But it's kind of curious that we don't have the same thoughts about other tests. We don't talk about the 2% that you might miss with stress, or with even more with ETT. So it concerns me, why do we care so much that we lose 1%? And when we were doing ETTs in the ER 15 years ago, we were losing 10% and nobody said, oh, what happens to the 10%? We're not gonna get perfect ever. There's a book that was recommended to me by a friend that's sitting in the audience called How Doctors Think. I haven't read the whole thing, but the idea is, why are we always concerned about missing one thing, but we're not concerning about making a mess of what we do? We send a patient that doesn't need a test to the cath lab, dissect the left main, and they die. So yeah, that's part of the life that happens, but we don't treat that as a potential implication of what we do, and have to think both sides. Sometimes the risk of just going further is just greater than not doing it. And we have to learn to pass that along to legal stuff. No, I don't think we have had, but we need to. Otherwise, we just kill people doing things because we say, I can't miss 0.001%. There has to be a threshold where we stop. I just don't know what it is, but we need one.
On that note, we're about a minute late, I think. I've been getting the from over here, so thank you very much.